Thank you for coming to the GI Complications and Management in CKD and ESRD. And it is my pleasure to announce Dr. Solani. She is an assistant professor in the Division of Nephrology and Hypertension at Vanderbilt University Medical Center. She is the medical director of the Vanderbilt Home Dialysis Clinic and is the program director for the Dialysis Fellowship at Vanderbilt University Medical Center. Her interests include dialysis, transitions of care, and green nephrology. So please welcome Dr. Megha Solani.
All right, thank you all for joining. I'm going to be going over a review of GI complications in chronic kidney disease and end-stage kidney disease. These are my disclosures. I am one of the authors for Up to Date on the GI complications and CKD section. And objectives, the goal is that after today's presentation, we'll be able to recognize and assess GI symptoms associated with kidney disease, how kidney disease and its treatment can impact the GI system, the prevalence and presentations of various conditions, and then how do we modify the management and treatment plan for these patients. What do we need to know as nephrologists as we're co-managing with primary care and gastroenterology? And just an overview of what we'll be covering. We'll go over GI bleeding, dysmotility, polycystic kidney disease, liver disease, pancreatitis, some miscellaneous rare diseases, and then certain medications that we use in CKD. So the gastrointestinal bleeding topics are going to be the answer options for our first question. So which of the following is the most common cause of GI bleeding in patients on hemodialysis? And there should be the poll that you can do. Peptic ulcer disease, angiodysplasia, ischemic colitis, uremic colitis, or variceal bleeding. All right, so most people got this one right, peptic ulcer disease. I always remember during medical training associating angiodysplasia with dialysis, and we'll go over why that is, but PUD is the most common cause. So just like the general population, it's the most common cause of GI bleeding and chronic kidney disease. You can see the pictures of a bleeding gastric ulcer before and then after treatment with epinephrine injection. So when the gastroenterologist is doing the endoscopy, they are looking at the ulcer for features that can indicate if it's at high risk or low risk for rebleeding. And that can then affect how closely the patient is monitored after the endoscopy. In patients that are on dialysis, there was a higher tendency for rebleeding even in patients that had low risk features on endoscopy. So it should be considered an independent risk factor, and those patients should be monitored closely. The management of peptic ulcer disease includes proton pump inhibitors. So while there is an association with acute interstitial nephritis, the risk of that is relatively low compared to the risk of bleeding with peptic ulcer disease. So that would be warranted in this situation. It's much better at managing than H2 receptor blockers. For patients that have something like H. pylori, which could be eradicated with antibiotics, the PPI may only be needed for a short duration. Or if someone has peptic ulcer disease due to NSAID use, which we would generally recommend avoidance of anyway, that might be a shorter duration. But generally speaking, if they have an ulcer that's complicated by bleeding, they will need the PPI for a long-term basis. Patients that have end-stage kidney disease do have a higher risk of GI bleeding with NSAID use. So even if they're not urinating and you're not trying to preserve residual kidney function, it is best to avoid at least, prolonged courses or high doses of NSAIDs. Peptic ulcer disease often causes pain. So if they're in the stomach, that pain is usually worse after eating, as there's more acidity in the stomach at that time. And then if it's a duodenal ulcer, it generally gets better after eating because the food is kind of absorbing that acidity. For gastric ulcers, sucralfate can be really helpful for the pain. But if someone has a GFR under 30 milliliters per minute, they are at risk for developing aluminum toxicity from sucralfate. So that can present with neurotoxicity, osteomalacia, anemia, and I would either recommend avoiding sucralfate or using it for a very short duration in those patients. All right, so angiodysplasia is a type of AV malformation, which you can see here. They can develop anywhere in the gastrointestinal tract. So as you can imagine, they may not be able to be reached by either upper and lower endoscopy if they're somewhere like this one where it's in the jejunum. These patients, if they're not able to have an intervention done, may have issues with chronic or recurrent bleeding. And the reason that we're taught to associate this with dialysis is because the risk of bleeding is quite a bit higher in patients that are on hemodialysis compared to the general population. The rates of bleeding isn't higher in chronic kidney disease or in patients on peritoneal dialysis. So that suggests it's not related to the uremic milieu, but something specifically about the hemodialysis. And there are several factors that could be contributing here. Hemodialysis patients are getting regular administration of heparin. So bleeding that may have not been clinically overt may become more overt and require intervention. They also have weekly hemoglobin levels checked. So if there's something that may have escaped notice, we may see a drop in the hemoglobin and investigate further and find AVMs. And then there's chronic platelet activation. So this is different from uremic platelet dysfunction, which we can see in advanced CKD and PD patients as well. But in hemodialysis, the exposure of the blood to the tubing causes platelet activation. And that is happening on a regular basis. So the platelets are just chronically activated, and it results in a kind of fatigue of the platelets over time. So they have dysfunction despite having the dialysis correct some of the platelet dysfunction from the uremic toxins themselves. So when patients do have prolonged bleeding, there are several different treatment options. Desmopressin works very quickly, so that one is helpful either for bleeding or prior to procedures where bleeding is anticipated. The uremic platelet dysfunction is related to platelet adhesion and aggregation. So the platelet count should be normal. Typically the PT and PTTs are normal. There are tests to look at platelet activity and aggregation, but uremic platelet dysfunction is generally a clinical diagnosis. So if there's a concern for it, then desmopressin is pretty safe. It would be just a one-time dose. There is tachyphylaxis or decreased effectiveness with repeated dosing. So it would just be given one time, and it should last for about 4 to 24 hours. So this could be very helpful for someone while they're waiting on endoscopic therapy. Cryoprecipitate is another option. It has clotting factors to help with platelet adhesion and aggregation. And then conjugated estrogens have been shown to have some benefit in prolonged bleeding. So if, for example, a patient who has a GI bleed, they have upper and lower endoscopy that don't show anything. and they're going to have a pill cam or video where there's a capsule that goes through the GI tract and takes pictures to find the cause. If that's going to be done outpatient, and it may be a while before they're able to have that done, IV estrogen can be given for 5 days to help with the bleeding, and it works for 2 to 3 weeks. There are some patients who have chronic bleeding and they're not in an area that is amenable to cauterization or embolization, and so they may end up needing this on a recurring basis. It is going to increase their risk of hypercoagulability, so that would need to be taken into account. And then EPO can be helpful. So this would not just be to correct the anemia, but to actually help with the bleeding risk itself. And the reason it works is EPO causes marginalization of platelets along the blood vessel wall, where they're going to be better at clotting. It's kind of the opposite of what you'd see with prednisone and white cells. And the other thing that it helps with is increasing the hematocrit. That just takes time, but as the hematocrit gets above 30%, there is more viscosity to the blood, which can also reduce bleeding. And then with dialysis, so again, this is one that you have to use your clinical judgment for. If somebody has advanced kidney disease and they're uremic and they're having bleeding, that could potentially be an indication to start dialysis. If they are already on dialysis and they seem underdialyzed either clinically or by labs, then it may be helpful to increase their dialysis. But if they're on hemodialysis and they're well dialyzed, then you wouldn't want to increase their dialysis because of that chronic platelet activation. Even though peritoneal dialysis patients have rates of AVM bleeding that's similar to the general population, there is a concern that when it does happen, it is more severe. And that is thought to be related to intra-abdominal pressure from the peritoneal dialysate. So if somebody is on peritoneal dialysis, potentially adjusting the PD, such as lower fill volumes or more while they're supine, could theoretically be helpful. There are some case reports about improvement after transitioning to hemodialysis, but it is a very rare phenomenon, so there's not a lot of literature in that area. All right, so ischemic colitis generally presents with sudden abdominal pain and bloody diarrhea. And if someone is on dialysis, and we see this, we may need to think about if it is triggered by intradialytic hypotension and manage that accordingly. So potentially holding antihypertensives before dialysis, adjusting the time and the UF rates to help. If someone is on hemodialysis and is having consistent issues with intradialytic hypotension, then peritoneal dialysis may be a good option. The care is just supportive, so making sure that they're well perfused, hydrated, and monitoring. If the patient is on peritoneal dialysis, there can be translocation of the gut bacteria into the peritoneal space, leading to peritonitis. And that is generally going to be with enteric organisms with one organism, although in 20% of the cases it could be a polymicrobial infection. Because ischemic colitis is just treated with supportive care, you do want to make sure you can differentiate this from mesenteric ischemia. So this would be related to atherosclerotic buildup and vascular calcifications, which is something we see in a lot of our dialysis patients. So the rates are pretty equal in hemodialysis and peritoneal dialysis. Acute ischemia is usually triggered by some low flow state and presents with severe pain. So this would be described as pain that's out of proportion to the physical exam. And those patients usually go to the ER because the pain is very severe, and that could warrant emergent surgical consultation. chronic mesenteric ischemia, the pain is not as severe, so this is usually not something that's sending people to the ER, but they tend to have pain after eating, and that can lead to fear of eating. So patients lose weight, they may have issues with malnutrition, failure to thrive, and if they say that they're having pain after eating, you can refer for revascularization. So uremic colitis is very, very rare. I haven't seen it personally. This would be something that would happen if someone's experienced all those more mild symptoms of uremia and did not get it treated, which most people are dialyzing before it reaches a point where they're having this sort of complication. But in that situation where someone does have untreated uremia, it would be really important to have an index of suspicion for uremic colitis. It presents with abdominal pain, nausea, vomiting, bloody diarrhea, fever, and the colonoscopy would show ulcers and pseudomembranes. So gastroenterologists who are seeing a lot more of ulcerative colitis or pseudomembranous colitis could misdiagnose this, and you wouldn't want someone to be treated for ulcerative colitis if they just need antibiotics and dialysis initiation. So you could initiate dialysis, treat this, and then reassess their gastrointestinal symptoms before seeing if they need any other therapy. Okay, so varices we generally think about with cirrhosis, but there are cases that have been attributed to SVC obstruction. So this may be in someone who has had a lot of dialysis access issues, or if they've had temporary and permanent dialysis catheters. And on the endoscopy, they will see downhill varices because the blood is kind of flowing down, trying to kind of compensate for the obstruction in the superior vena cava. And referral for angioplasty would be helpful for these patients. So when a patient is undergoing endoscopy, if they have chronic kidney disease or end-stage kidney disease, we generally recommend polyethylene glycol solutions and avoidance of phosphate-containing preparations because of the risk of hyperphosphatemia and phosphate nephrotoxicity. For patients that are on peritoneal dialysis specifically, we recommend antibiotic prophylaxis. So the ISPD recommends prophylaxis prior to lower endoscopy because the rates of peritonitis afterwards are very high. The rates of peritonitis after upper endoscopy are not as high, but they're still higher than baseline, and that's been shown very consistently. So I recommend prophylaxis prior to either one. You would want the patient to be completely empty prior to the procedure, and then hold PD for 24 hours after endoscopy. And if they have a colonoscopy with polyp removal or biopsies, and there's no urgent reason to dialyze them, then you may wait 72 hours. If this is a planned procedure, I'll often have my patients do more dialysis kind of going into the procedure in anticipation that they may have to hold it for a bit. And the reason that we do that is because there's a thought that having the peritoneal space empty is better for the function of white cells and the immune system. So you are more easily able to fight off those bacteria that have translocated into that space. And you don't have the sugar solutions that they could potentially grow off of. The rates of peritonitis after colonoscopy, if they're not giving antibiotics, is reported as 3.4 to 8.5%, and after upper endoscopy, 1.2 to 3.9%. All right, so now we'll move on to dysmotility. And we'll start with gastroesophageal reflux disease, or GERD. This will present with heartburn, regurgitation. It can present as a dry cough. And treatment, if they're using H2 receptor blockers like famotidine, would need to be renally dosed. Again, PPIs are stronger, so if the H2 receptor blocker isn't working, that would be a potential alternative, with that in the back of your mind that there is an association with the interstitial nephritis. Antacids can be tricky for our more advanced kidney disease and dialysis patients because they're available over the counter, and sometimes people use them fairly frequently, and you may not be aware of the use. A lot of antacids contain aluminum hydroxide, so that same concern for the aluminum toxicity that we talked about with sucralfate is there. And then some antacids have calcium, so patients with hypercalcemia, if you ask them about calcium supplements, they may not be aware that things like Tums and Rolaids are included in that, so it helps to ask specifically. There is subjective data from dialysis patients that GERD is more prevalent in PD patients compared to patients that are on hemodialysis, which is likely related to that increase in intra-abdominal pressure. Gastroparesis is something that we tend to see more commonly in patients with diabetes because of the effects of the blood sugars on the nerves over time. And patients that have frequent flares or severe flares may have progressive kidney dysfunction from volume-mediated AKI episodes. So a lot of the medications that we use to treat, particularly diabetic kidney disease, play a role in this. So ACE inhibitors, ARBs, SGLT2 inhibitors, finerenone, all of these things may exacerbate an AKI in the setting of volume depletion. And so if you know somebody has these flares, you may need to educate them about when to hold those medications. And depending on the clinical scenario, there may be times where the risk outweighs the benefit for those medicines. Semaglutide has had really good evidence for slowing progression of kidney disease and type 2 diabetes. However, it does affect gastric motility. So if somebody already has gastroparesis, then this may not be the best option for them. I generally tell my patients if they are starting this or if they're increasing the dose and they start to have severe nausea or vomiting, to stop it and let me know, because that is where we tend to see more issues with acute kidney injury. The treatment for gastroparesis includes small, frequent meals. They have delayed gastric emptying, so smaller meals allows them to be able to empty their stomach before they have issues with vomiting, and then increasing the frequency so that they're still getting the nutrition they need over the course of the day. Metoclopramide, renally dosed, is helpful for the actual emptying, and then antiemetics don't help with the gastroparesis, but they can help with the symptoms of nausea that are associated with it. Interestingly, the gastric emptying is slower for patients that are on PD compared to hemodialysis. So when that fluid is in is where it's the slowest, but even after the fluid is drained out, the delay in gastric emptying is persistent. So it may not be just related to intra-abdominal pressure, but also related to the caloric intake from the dextrose solutions, and how that impacts the body. So there's more delay in patients that are using dextrose than when they have icodextrin. All right. The management of constipation for patients with kidney disease is very similar to the general population, with hydration, physical activity, fiber-rich diet, probiotics, stool softeners, and laxatives. The main difference is that we want to avoid phosphate and magnesium-containing cathartics, particularly if they have moderate to advanced kidney disease or end-stage kidney disease. And with magnesium, even though it causes diarrhea, it can start to accumulate in patients that don't have enough kidney function to excrete it. And as magnesium accumulates, you can have issues with the solubility of it in the gut. And so patients can have a risk for magnesium B-sores, which cause constipation and potentially obstruction. We really try to stay on top of constipation for patients that are on peritoneal dialysis because it really affects their therapy. So even if patients are saying that they're having bowel movements every day, they may still have stool burden that affects their PD. The constipation can affect the outflow of the dialysate. So normally with constipation and omental wrap, the PD fluid is able to go in okay. It can kind of push things away as it's going in, but it's the trouble getting back out of the body. And that is because there's just a lot of pressure there that is kind of preventing the fluid from being able to get into the catheter where it can reach it. Sometimes with severe constipation, the catheter can even migrate. And so on this KUB, you can see that there's quite a bit of stool burden, but the PD catheter is still where it should be in the mid-pelvis. But if the constipation causes catheter migration, you want to be able to differentiate this from omental wrap, which would also cause catheter migration. And so you need to know if you want to treat it with laxatives or if it needs a surgical consultation. So KUBs are really helpful because you're seeing both the catheter placement and the stool burden. Constipation can increase infusion pain and drain pain in patients on peritoneal dialysis. Because the fluid is not able to come out as easily, if there's fluid that remains in, it will get reabsorbed, and this can lead to fluid retention and inadequate solute clearance. So for patients that are on peritoneal dialysis on the cycler, there's a couple different settings you can use. There's a time-based setting. So if I say I want my patient to have 4 exchanges over 8 hours, they are going to be on the machine for 8 hours. And if they have constipation that is causing slower draining, that is going to cut into the dwell time, the amount of time where the fluid is in and solutes can go out of the body into it. Those toxins can be removed. And so you decrease your clearance. There's also a setting that would be cycle-based, so they're going to get those 4 exchanges regardless of how much time it takes, which can be good in the sense that they're getting better clearance when the drain time slows down, but it can be frustrating for patients because they're expecting to be on the machine for 8 hours and now they may be on for 8.5 hours. Constipation also can lead to abdominal fullness, discomfort, nausea, things that can lead to poor nutrition, which is a very poor prognostic factor in dialysis. And then there's an increased risk of peritonitis. All right, so for polycystic kidney disease, which of the following is not associated? Diverticulosis, abdominal hamartomas, abdominal wall hernias, liver cysts, or pancreatic cysts? Okay, great. The one that's not associated would be abdominal hamartomas. That is typically seen with tuberous sclerosis complex, but all of these other things can be seen in polycystic kidney disease. The other GI complications of PKD include early satiety if the kidneys grow large enough, and the kidney cysts themselves. So patients may develop kidney cyst rupture, which would be really painful. They can have cyst hemorrhage, which may or may not communicate with the urinary tract. So sometimes they'll have hematuria, but sometimes they may just have symptomatic anemia or incidentally found anemia. The hemorrhage generally will self-resolve, but it helps to have them monitored in the hospital if that's going on so that you can make sure they don't need blood transfusions or hemodynamic support. Cysts can also get infected, so this generally will present with CVA tenderness and fevers. Again, it may not communicate with the urinary tract, so the urine sample may not look infected, but you'd still want to treat for a cyst infection. And we usually use ciprofloxacin because it has very good cyst penetration. Diverticulitis, sometimes patients with polycystic kidney disease or patients that don't have polycystic kidney disease can have recurrent diverticulitis. And depending on how often they're having flares and how severe they are, transplant may want the patient to undergo an elective sigmoid colectomy prior to transplantation so that you're not having to deal with diverticulitis after having all the immunosuppression. Diverticulitis isn't a contraindication to peritoneal dialysis, but should be considered if someone's having recurrent flares that is going to put them at really high risk for recurrent peritonitis. All right, so we'll move on to liver disease. So first I'm going to talk about hepatorenal syndrome. The classification for this changed relatively recently from HRS type 1 and type 2 to HRS AKI and HRS CKD, but the concepts are the same. So the initial issue is related to the liver fibrosis, which causes an increase in the portal pressures. And that causes production of vasodilatory factors like nitric oxide, carbon monoxide. With the splanchnic vasodilation, you get a redistribution of the blood flow, which ultimately decreases the mean arterial pressure. Once that happens, there's an activation of compensatory mechanisms. So RAS and the sympathetic nervous system and AVP are all activated, which can cause issues with sodium and water retention and ascites, hyponatremia. With the low MAPS, you start to have these vasoconstrictors that can cause renal vasoconstriction, which can lead to that HRS AKI phenotype. So this would be really severe vasoconstriction of afferent glomerular arterioles. One of the things that you tend to see is that the urine sodium level in HRS is very, very low, and that is because there's just extreme vasoconstriction. So regardless of how much fluid you're giving, it stays low. Treatment of this depends on the cause. So there are cases of HRS with acute alcoholic hepatitis, which can be reversible as the liver improves. But if it's from cirrhosis, then those patients would need a liver transplant for the kidney function to get better. When HRS was first being, kind of seeing what was going on, they realized that patients that had liver transplants, the kidney function would get better without any other therapy. And patients that had HRS, if you took the kidney out and gave it to someone who had normal liver function, the kidney would work normally in that patient. So even on histology, there's no changes. But usually we're not biopsying these patients, so we would generally have this as a diagnosis of exclusion where you've ruled out other reasons and the physiology fits the picture. In that situation, you would use vasoconstriction, so that could be midodrine and octreotide or norepinephrine with albumin. And if that is working, it can be continued up to 2 weeks. If it's not working, it is a very poor prognostic sign for the patient. So if they're not a liver transplant candidate, the mortality rate is very, very high. The prognosis is poor. And depending on what the clinical situation is and the liver transplant candidacy is, renal replacement therapy may or may not be appropriate. Another potential therapy, which can work well for people who have recurrent ascites, is a TIPS procedure. And that you just have to think about the risk of hepatic encephalopathy. Okay, so for bile cast nephropathy, we tend to see this in cholestatic or liver diseases that cause very high bilirubin levels. So if you see, levels in the 20s, 30s, you could potentially see progressive kidney disease or AKI from bile casts. This first picture is the urine sediment, so you can actually see this in the urine itself. And then you can also see it on histology if someone has a kidney biopsy. All right, and then hepatitis B and hepatitis C can both cause issues with liver disease and cirrhosis, but they can also be associated with various kidney diseases. So out of the following, which one is not associated with hepatitis B or C? Membranous nephropathy, MPGN, polyarteritis nodosa, or cryoglobulinemia, or anti-GBM disease. I don't know if this one gave all the options. May not have. Okay, well, I'm not giving you a shot if there's not all the options. So it is anti-GBM disease. The rest of those can be seen with viral infections. And so patients with cirrhosis, if they have hepatitis that's active, those things could be a consideration. There's also increased IgA deposition in cirrhotic patients. That doesn't necessarily translate to IgA nephropathy, but there is a higher rate of that compared to the general population. So a lot of risk factors for kidney disease in patients who have liver disease. If they progress to end-stage kidney disease, the cirrhosis in and of itself doesn't dictate what the modality option should be. So there are some concerns. Patients that have chronic hypotension may have a difficulty tolerating hemodialysis or have more issues with intradialytic hypotension. They're having blood access and they may have coagulopathy from the liver disease. And then as you're doing hemodialysis, you're pulling fluid directly from the blood vessel, and that fluid has to refill in order to prevent a drop in blood pressure. So patients that have a lot of ascites, you're not going to be able to easily access that fluid for refilling. And liver patients tend to have low albumin levels, which can cause a low oncotic pressure within the blood vessel. And so it's very difficult to try to manage ascites with hemodialysis, similar to pleural effusions, where usually you need a tap. You can't manage it just with the dialysis a lot of times. And so sometimes patients end up needing weekly or biweekly paracentesis because the ascites will just continue to accumulate. With peritoneal dialysis, you do have protein losses. So initially the albumin level does decrease after starting peritoneal dialysis, but it does tend to stabilize thereafter. Patients that have cirrhosis sometimes get spontaneous bacterial peritonitis. So of course, that you may be worried about peritonitis increasing, although the literature suggests that that's not a huge concern. And then the effect of the ascites on volume and clearance. So if somebody has ascites, it can be kind of nice to be able to drain it with the dialysate where you're not having to worry about doing paracentesis. So in some cases, the ascites that is generated decreases over time with peritoneal dialysis. So this could potentially not be an issue, but if someone's continuing to develop ascites and they have dialysate in there, it can lead to overfill, which can then cause volume overload because that fluid has to go somewhere, which is mimicking heart failure, and then it can lead to a decrease in clearance or inaccurate measurements of clearance. So it's not a contraindication. I think it's still worth trying, but that is something that might make you have to change course if that was an issue. The meta-analysis of small studies shows no mortality difference using either hemodialysis or peritoneal dialysis. So either one, depending on patient preference and other factors that would normally make you decide one way or the other. All right, so for pancreatitis, this can be associated with some of the medications that we prescribe, like thiazides and ACE inhibitors. If someone has pancreatitis that's thought to be due to ACE inhibitors, you would want to switch over to an ARB because that does have less incidence of pancreatitis. I don't think anyone can tell you why, but there is a higher incidence of pancreatitis, both acute and chronic, in patients that have end-stage kidney disease compared to patients with chronic kidney disease or the general population. There's some data, although it's not strong, that the incidence may be higher in patients that use peritoneal dialysis. But overall, the outcomes are very similar. Of course, when patients have advanced kidney disease, or certainly if they have end-stage kidney disease, you just have to be cautious with fluid resuscitation because patients with pancreatitis are generally getting very, very high rates of saline or isotonic fluids. All right, so for rare diseases, I'm going to start with calciphylaxis. So normally we think of this as a skin disease. They get painful necrotic lesions, but it can involve internal organs, and sometimes this is in the absence of any skin findings. So you wouldn't necessarily be able to diagnose it until something bad happens, unfortunately. On the image here, you can see that there's quite a bit of vascular calcification in the arteries throughout the abdomen, but there are so many patients that have vascular calcifications that never get calciphylaxis, so you can't base it off of imaging. If someone has issues with bowel necrosis and hemorrhage and they get a resection, then you could ask, especially if you think that there's a risk of calciphylaxis, for histology to look for that, because you'd want to know if they need treatment, like sodium thiosulfate, in addition to the treatment of the necrosis. So dialysis-related amyloidosis isn't seen very commonly. It used to be seen more commonly, but with our current biocompatible high-flex membranes, you get some removal of beta-2 microglobulin. It's not a huge amount, but enough to usually prevent complications. And then there's more removal with therapies like hemodiafiltration. And with these medium cutoff dialyzers. So depending on how these emerge across the US, we may see even less of dialysis-related amyloidosis. When it does occur, it generally presents as shoulder pain, carpal tunnel. So if you see bilateral carpal tunnel, that could be a consideration. Trigger finger, things like that. Although rarely it can affect the GI tract, and this would lead to bleeding, mesenteric ischemia, bowel obstruction, bowel perforation. Because it's related to the beta-2 microglobulin, increasing clearance would be the goal for management for this. So if patients are on hemodialysis, increasing their time is helpful. If they're on peritoneal dialysis, they're really relying on their residual kidney function to remove the beta-2 microglobulin. So if it's accumulating, they probably need to transition to hemodialysis. And then the next rare disease is encapsulating peritoneal sclerosis, but I did just want to take a minute to kind of comment on the abdominal pain issues that we see that are kind of unique in peritoneal dialysis. So first would be infusion pain. This can be seen fairly frequently in patients when they first start peritoneal dialysis, especially if it's urgent start and that catheter had just been placed. There's still a lot of inflammation intra-abdominally, and that can potentially get better over time. But sometimes patients have persistent issues with this, and this is likely due to the acidity of the dialysate fluid. So in other countries, they do have various pHs, but in the US, we only have acidic dialysate. And a possible way to help with this would be to add bicarbonate into a manual bag and have them infuse that, which can help with the pain. Another possible option is lidocaine. Patients also can have drain pain. So as the dialysis fluid is draining out, at the very end, there tends to be kind of like a suction feeling. That can be really uncomfortable. I've had patients describe it as like they feel like something's sucking on their internal organs, which is kind of what is happening. The drain pain is much more common with cycler than with manual exchanges. It can happen with manual exchanges, but generally patients will just stop pulling once that happens. But with the cycler, it may be searching for a certain amount of fluid. And so you may need to change the setting so that it's not expecting so much if you overshot, and that's the cause of the drain pain. Sometimes that's not the cause, and it can help to add a tidal volume. So this would be a small amount of the PD fluid that's not drained, and it floats the catheter so that it's not kind of causing that suctioning phenomenon. If you kept leaving fluid in again and again and not pulling it off, eventually that could lead to overfill and heart failure. So you eventually have to drain all the fluid off, and that's usually going to be with the last drain on the cycler. And then on the cycler as well, they have an initial drain, which is going to happen whether there's fluid in or not. So it can be helpful to leave a small last fill in patients who are doing incremental PD, just to help with that. Peritonitis will cause abdominal pain and cloudy fluid, and you can check cell counts to see if they have peritonitis. Most peritonitis is going to be infection related. So even when there's kind of a sterile peritonitis or culture negative peritonitis, that's still most commonly infection related. But you can have chemical peritonitis, which is more common when people start. So when they first start PD, or if they just started adding icodextrin, they might have this. And then sometimes it's related to additives that are in the PD fluid. So for example, sodium thiosulfate, which is treatment for calciphylaxis, we usually will do IV because of high rates of chemical peritonitis if it's added in intraperitoneally. Eosinophilic peritonitis, you do have a high eosinophil on the differential of the cell count, so that helps with the diagnosis, but you still want to treat for infectious peritonitis until you know that it's not, so until that culture is negative. Eosinophilic peritonitis is also associated with addition of medications into the dialysate, which can often be stopped, and then with icodextrin, sometimes that's seen. And it may resolve, and sometimes people will need a short course of steroids to help. with encapsulating peritoneal sclerosis. So this is a very rare phenomenon. Is associated with long dialysis vintage. So there's not a cutoff. If someone's been on peritoneal dialysis for 10 years, you wouldn't stop it just because this is a risk, because it's such a rare complication. But if they present with abdominal pain, poor intake, nausea, vomiting, sometimes they have ultrafiltration failure, weight loss, intestinal obstruction. If they're having symptoms that make you concerned for this, then you would want to do a CT to diagnose. And this can even be seen following transplant. So someone who was on PD for a long time before they got transplanted, sometimes years after transplant, this could be the presentation. It's also been reported in patients that have never been on peritoneal dialysis, but it is more commonly seen in patients that have been on for a long time. The CT, as you can see here, this is pretty severe changes. So you see the bowel kind of drawn into the center of the abdominal cavity, and you can see ascites around it. Oftentimes this ascites will be loculated because of adhesions. And normally you don't see the peritoneal membrane on scans, but here you can see it kind of along the outlines and inside because of the thickening that occurs with it, the peritoneal thickening. There's some calcifications, the white areas kind of along the side of the ascites. So all of that would be consistent with EPS. This is a little bit controversial, but most people do recommend stopping PD if they develop this. And then if it's caught very early on and it's still in an inflammatory state, steroids may be helpful. But because of the kind of slow process of the worsening symptoms, we often don't diagnose this until it's more fibrotic in nature, in which case steroids are not going to be helpful. There have been some use of tamoxifen off-label that has had success. But the mainstay of treatment is aggressive nutritional support. So EPS has a very poor prognosis, and the high mortality rate afterward is generally related to malnutrition. So if you can, do tube feeds or something like that, then it can really change the course for these patients. All right, and then last we're just going to talk about some medication considerations. There are a lot of medications that we use in CKD that cause GI effects, but I was just going to focus on kind of our management of hyperkalemia and mineral bone disease. So for hyperkalemia, one option is sodium polystyrene sulfonate, which is a cation exchange resin. This can cause damage to the intestinal mucosa, especially if it's given with sorbitol or if it's kind of staying in the colon for a prolonged time. So possible ways to prevent this would be administering without sorbitol. And generally you're not using this for chronic hyperkalemia, but if you're needing it, outpatient for multiple uses, you may ask the pharmacist to make sure it doesn't have sorbitol because it's not something you can easily order. Another option would be an enema, so that prevents that colonic exposure, but it still works really well to get rid of the potassium. And then the newer potassium binders don't have reports of any intestinal necrosis or mucosal damage, so that would be a good alternative if the cost is not prohibitive. Right, and then pretty much all of the binders that we use for phosphorus have the risk of nausea, vomiting, constipation, and diarrhea. With calcium-based binders, they can also develop hypercalcemia, which could cause abdominal pain. Sevelamer and lanthanum, I would argue not to use those in patients that have a history of ileus because of the risk of kind of intestinal mucosal injury if they do develop severe constipation. Iron-based binders, I will warn my patients that their stools are going to be dark so that they don't freak out when their stools turn black. And if they're on ferric citrate, you want to monitor for iron overload because the iron is absorbed with that one. Cinacalcet can cause nausea and vomiting, especially if it's given on an empty stomach. So you want patients to take this with food. And then it is more likely when they're on higher doses. So this is generally a once-a-day medicine, but some patients may tolerate it better if it's a lower dose twice a day. And then, so in someone who has intestinal mucosa damage from sevelamer, if you looked at the histology, you would see these kind of fish scale pattern. This looks very similar to what the SPS looks like, except those fish scales are more narrow. So the histology can tell you that this is going on, and then you would want to avoid sevelamer use going forward. This is really rare, but as the use of sevelamer becomes more and more common, it's more likely that you'd see something like that. All right, and then there should be lots of time for questions.
Okay, so one of the first questions is, in patients with upper extremity hemodialysis access and GI bleeding, how often should we consider superior vena cava syndrome and variceal bleeding?
So I wouldn't put it like high on your differential, but if you see varices on, or not you, but the gastroenterologist sees varices in the absence of cirrhosis on endoscopy, then that would warrant evaluation for, like their central stenosis and SVC obstruction.
And then, should we screen PD patients more for GI complications due to higher pancreatitis and dysmotility and ESRD? And could this affect modality selection?
Yeah, so that's a great question. And I think I personally would not have that as a reason to select a particular modality, but it could be a consideration if someone's really not doing well. Like if they start on peritoneal dialysis and they get much worse issues with gastroparesis, let's say. So that could be an indication that it may not be working well, which if you don't know that PD can exacerbate that, you may not know, a lot of our patients get gastroparesis, so it would be easy to overlook that. I wouldn't say that there's any screening necessarily, so like I wouldn't do a gastric emptying study on all comers. It would really only change your management if it was clinically relevant. And even with pancreatitis, there's very, very little data to say that it's more common in PD, and certainly no data that says it has worse outcomes. So if they have the clinical symptoms, you could evaluate for it. You could kind of see if there's any adjustments that you should be making to your prescription. But I don't think there's any screening process or any absolute contraindications.
Very good. Do you have ESRD patients on hemodialysis complaining of chronic diarrhea? Is this related to fluid shifts? And besides giving Imodium, do you have any other suggestions?
I have had some patients that complain of diarrhea, and they've had a pretty negative GI workup. It may be that they have some micro colitis or something that's not easily seen on endoscopy, in which case, yeah, like Imodium, things like that may be helpful. I don't know that there's anything you can do with the hemodialysis to really impact that. The osmolality shifts shouldn't be causing worsening diarrhea. But I have had patients that say it's always worse after their dialysis session, so I could be wrong.
And should bowel regimens be standardized and protocolized in PD patients given the link between constipation and poor PD clearance or peritonitis risk?
Yes, so before the PD catheter is placed, we have patients undergo a bowel regimen, which just consists of a laxative and a docusate suppository. And then if they're going to undergo any surgery just because of the risk of decreased transit after anesthesia, we'll do the same thing. So we make sure that they're really cleared out and prior to the whatever procedure they're undergoing. On a day-to-day basis, it's not a bad idea to have patients take stool softeners daily or twice a day, and they could certainly stop that or reduce it if it's causing issues with too loose stools. But that can really help just to prevent issues, and then if they're constipated, then doing a laxative, but I wouldn't do the laxative on a daily basis to prevent issues.
Thank you. And should we screen long-term dialysis patients with GI bleeding? Wait a minute. Should we screen long-term dialysis patients with GI bleeding for dialysis-related amyloidosis? And if so, what tools, biopsy, imaging, or serologies are useful?
I wouldn't screen because this would be probably the least kind of likely cause of a GI bleed. But if there is a biopsy that's taken that would be diagnostic for amyloidosis, if it's present, then you could do more dialysis. If someone has a GI bleed, usually they're having some sort of tissue sample taken, so you would know if there was some issue.
Thank you. And when calciphylaxis is diagnosed in a PD patient, do you automatically switch them to hemo or do you keep them on PD?
I keep them on PD unless there's some reason not to. So if they're really non-adherent with their dialysis and you want to make sure they're getting good clearance so that their phosphorus can be better controlled, then you could make an argument to switch to hemodialysis. But generally speaking, I would keep them on peritoneal dialysis. Make sure that they're not on any calcium-based binders or calcium supplements, that they're not on any vitamin D analogs, and then still using the same like cinacalcet, parathyroidectomy if it's needed. Getting really good control over their phosphorus, so maybe being more aggressive with the non-calcium based binders. And peritoneal dialysis, similarly to hemodialysis, the phosphorus removal is kind of time dependent because it is going to take longer to go through those pores in the peritoneal membrane. So if they're only on cycler, you may want to add a last fill or a long dwell to really help with phosphate clearance. And that would be the type of patient that, maybe they need dialysis 24/7 as opposed to incremental if you really want to make sure that that's in a good range. But you can certainly keep them on PD. And then the only issue, so because they're on peritoneal dialysis and they're not going to get sodium thiosulfate with their dialysis treatments, you would want to set up some sort of, IJ PICC line or something so that they can get their infusions of it.
Okay. And what is the latest data supporting or not supporting the use of sodium thiosulfate for treatment of calciphylaxis?
So the data is very good. Calciphylaxis, untreated, had a mortality rate of 80%, and that has been reduced drastically with the use of sodium thiosulfate. It doesn't always work, but there have been instances where people have complete resolution of the calciphylaxis after starting it. And the mechanism of action isn't entirely clear, but it has better outcomes than pretty much everything else that has been tried.
Very good, thank you. Are there any other questions? Sure, yeah.
So I'm Jamin Patel. I'm one of the nephrology fellows over at UC. GI has been a magical place for us as fellows learning about dialysis. But one of the questions that I had was all of the different manifestations of GI complications when it comes to peritoneal or in-center hemodialysis. Do those go away when you switch patients to home hemodialysis? Like, do the risk of developing angiodysplasia or peptic ulcer disease, all those things, do those decrease? Are we seeing that?
Yeah. So for home hemodialysis, there's a few different ways to do it. Sometimes people are only doing it 4 days a week. And sometimes people are doing, 5-6 days a week. And then the duration of it also can be very variable. So when people are getting 4 days a week next stage, they're probably not going to have any difference compared to their in-center counterparts. But so just to kind of go through the different issues. So for angiodysplasia, we don't actually know that patients on dialysis develop more angiodysplasia. We just know that they bleed from them more often. So the malformation makes the blood vessels very fragile and it's easier for them to bleed. Patients on home dialysis may still need heparin. Not all of them do, but oftentimes they do. And in that situation, they're still having the same kind of exposure of the blood to the tubing, the heparin, risks for having more issues with bleeding. With the ischemic colitis, so the rate of intradialytic hypotension per session is lower with home hemodialysis or frequent dialysis, but the instance of intradialytic hypotension over the course of the week is not lower because you have more sessions. So it would still be a potential complication. And then, so for these sort of things, the rates in hemodialysis are not as affected as for patients on peritoneal dialysis. So in-center versus home shouldn't make a difference. I think home hemodialysis, even though they still can have issues with intradialytic hypotension, can be really helpful for people who have cirrhosis because it's just a little gentler. It's more often. So these are people who, again, they have issues with fluid retention that's really hard to get at with dialysis. So if you can do it more frequently and have to take less off per treatment, I think that's really helpful. And then, for amyloidosis, I think if you're doing more frequent, that's going to certainly help. Does that answer your question?
Very good. Any other questions? All right. Well, thank you, Dr. Sabine.
Thank you.